This lecture is about lung aging, specifically the physiologic, histologic, and disease-relevant changes that occur in the lung as it ages. As you know, the U.S. population is rapidly aging, as are the populations in most industrialized countries. This reality has forced us to understand the aging process better and propose strategies to recognize and address associated impairments at the earliest possible stages. Our first case is that of a 75-year-old man who reports shortness of breath with walking up one flight of stairs that has developed over the last 1 to 2 years. He denies any cough, chest pain, or sputum production. He also denies any history of asthma, pneumonias, or bronchitis. He is a retired draftsman, and he's a lifelong non-smoker. His physical exam reveals a height of 5 feet 7 inches tall and a weight of 178 pounds. His heart rate is 80 beats per minute. His blood pressure is 135/95, and his respiratory rate is 15 breaths per minute. On room air, his oxygen saturation is 91% at rest. His chest exam shows that he's kyphotic, with reduced respiratory excursion and dry crackles at both lung bases. An electrocardiogram as well as an echocardiogram are both within normal limits. A chest X-ray that you see here shows clear lung fields with bibasilar interstitial prominence and no effusion. His spirometry is depicted on this slide. He has an FEV1 of 1.43 liters, which is 60% of predicted, a forced vital capacity of 2.21 liters, which is 75% of predicted, and an FEV1 over FVC ratio of 65%. This profile is consistent with a mixed obstructive and restrictive pattern. I want you to note the coving at the terminal phase of this flow volume loop that is consistent with small airway obstruction. I also want you to notice the reduced dimension of his lung volumes when you compare it to normal lung volumes depicted with the dotted line. So our question is whether these changes are related to aging or to aging-related lung disease. How do we distinguish these concepts? First, aging-related changes are the normal age-related alterations in lung physiology, whereas aging-related diseases are lung diseases that disproportionately develop in aged persons. For example, COPD and lung cancer are observed in older smokers. Idiopathic pulmonary fibrosis develops disproportionately in older people, and restrictive chest wall diseases like scoliosis and kyphosis are overrepresented in older persons. So our first question is, does the lung age in a stereotyped fashion? 3 observations are of interest. First, lung function declines with normative aging. This has been demonstrated both in cross-sectional studies and in several longitudinal cohort studies, which serve to minimize the cohort-specific effects. Second, there is a loss of pulmonary reserve with aging. What this means is that direct or indirect pulmonary insults, be they infectious, toxic, or inflammatory, result in a greater deterioration in lung function and health status in older persons than that experienced by a younger person. For example, bacterial and viral pneumonias in older people will often require hospitalization and sometimes intensive care, while in younger persons, these can typically be managed in an outpatient setting. Third, there is a greater susceptibility to pulmonary infections with age. This is often linked to expanded multimorbidity with aging. However, other contributors include differences in host defense, such as reduced response to vaccines, impaired cough reflexes, and reduced mucociliary clearance, which we will discuss later. This slide depicts the effect of aging on lung function using the spirometric measure of FEV1 in a large cohort study. As you can see, in 3 different ethnic groups and in both genders, the same trend is evident. Peak lung function occurs at approximately 25 years of age in men and approximately 18 years of age in women. There is a subsequent steady deterioration in lung function. An important conclusion from this study is that if one starts out with less than optimal peak lung function, the likelihood of developing symptoms of aging-related respiratory impairment is increased. The seminal physiologic changes that occur with aging are intimately related with the increase in alveolar dimension, which, like an emphysema, is associated with reduced elastic recoil and increased compliance. An increase in alveolar dimension, which is not accompanied by an increase in lung growth, results in a reduction in alveolar surface area, which we see with aging. The reduced elastic recoil clearly contributes to airflow limitation. However, another factor contributing to airflow limitation is the loss of alveolar attachments or stents to the airway, which causes reduced airway luminal area and obstructive physiology. As in asthma and COPD, the airflow limitation is associated with increased residual volume or air trapping. The histology on this slide shows the increase in alveolar dimension in the aged lung compared with the young lung that is very reminiscent of what we see with smoking-related emphysema. This loss of tissue is not due to active inflammation with alveolar wall destruction. Rather, there are cell-autonomous senescent processes that result in cellular and tissue dropout. Let's examine the compliance changes with aging in more detail by not just looking at the lung parenchyma, but also looking at the musculoskeletal compartment. The musculoskeletal thoracic compartment is comprised of the ribs, sternum, spine, and the respiratory muscles, including the diaphragm. Although I told you that the lung compliance is increased with aging, the chest wall, or specifically the thoracic cage compliance, is reduced with aging. This is because there is rib cage stiffening that is often accompanied by kyphosis, the exaggerated AP curvature that is shown on the left at the bottom of the slide. On balance, the reduction in chest wall compliance is greater than the increase in lung compliance. Accordingly, the total respiratory compliance is reduced. The respiratory musculature behaves like the other skeletal muscles with aging. As you know, one of the classic features of pathologic aging is sarcopenia, or loss of muscle mass, which is a critical component of the frailty syndrome. So not only are the limb muscles weak, the respiratory muscles become weaker with aging. So the combination of rib stiffening, reduced skeletal compliance, and weaker respiratory muscles culminates in a restrictive profile on pulmonary function testing. So as you can see, aging can result in the complex respiratory picture of both obstructive and restrictive lung physiology. This slide gives us another way of looking at the compliance changes with aging, employing the pressure volume curves that you're quite familiar with. Here we distinguish the chest wall, lung, and total respiratory system tracings. We see here with aging, there is a significant increase in the compliance of the lung, but a more substantial reduction in the compliance of the chest wall. This serves to reduce overall respiratory compliance, depicted here by the solid yellow curve. Let's see what happens to the static lung volumes with this. We see that there is an increase in the residual volume and the functional residual capacity, but a more modest reduction in the total lung capacity with aging. We show these changes again with this display that depicts the tidal volume to forced vital capacity maneuver. We see here that the increase in residual volume is greater than the increase in FRC with aging, resulting in reduced expiratory reserve volume. This translates into increased air trapping, which is a common feature of obstructive lung disease. Note that there is no significant increase in the total lung capacity, which distinguishes lung aging from COPD and emphysema. The changes that we have described in detail are summarized in this slide, which depicts the static lung volumes over time. Again, we see that the residual volume increases over time. The FRC increases, but at a slower pace over time, and the changes in TLC are minimal. A common pathologic finding of the aging lung is excessive extracellular matrix production, especially collagen, which is deposited in the alveolar wall and the airway wall. These are lung sections from young and aged mice where we see a reduction in elastin staining, but an increase in collagen staining in the lung parenchyma with aging. These histologic changes parallel our physiologic findings of increased lung compliance that often associates with reduced elastin deposition in diseases such as emphysema. The increase in collagen may create a predisposition to clinical lung fibrosis, which is increased in aging populations. Additionally, increased extracellular matrix deposition in the airway wall contributes to further airway obstruction. Other findings in the aging lung include a reduction in the microvasculature or the capillary bed and an increase in airway mucus glands. This latter finding may contribute to the altered mucociliary clearance with aging. Another physiologic change that accompanies aging is an impairment in hypoxic and hypercarbic respiratory drive. We see here an assessment of hypoxic ventilatory responses in young men under isocarbic conditions. That means the CO2 levels are kept constant. You can appreciate ventilation on the y-axis and the alveolar oxygen pressure on the x-axis. The ventilation shows a marked upward inflection at 50 millimeters of mercury. By contrast, in aged men, we see an attenuated ventilatory response to hypoxia. This impairment in chemosensory responses directly contribute to the reduced pulmonary reserve of aging. What about exercise capacity? Based on what we just discussed in terms of lung mechanics and ventilatory responses, it should not be surprising that tidal volume and minute ventilation falls with aging. Because of fatigue in non-diaphragmatic respiratory muscles, there is an increased reliance on diaphragmatic breathing. Overall, these impairments result in reduced breathing efficiency and reduced maximal ability to ventilate. Specific airway impairments contribute directly to disease predisposition in the aged. Of note, poor airway clearance can lead directly to aspiration pneumonia, community-acquired pneumonia, and chronic lung inflammation. Several factors contribute to poor airway clearance with aging. There is altered mucociliary clearance that may involve the aforementioned mucus hypersecretion. There is reduced airway smooth muscle function, and there is also reduced cough strength. Let's talk briefly about host defense and the complex immune disturbances with aging. These changes have been termed immunosenescence or inflammaging. There is an increase in general inflammation reflected in enhanced pro-inflammatory cytokine production, inflammatory cell influx into tissues, and increased antibody production. However, despite this basal increase in inflammation, there is an impaired ability to coordinate a targeted immune response to specific pathogens. The consequence is a systemic chronic multi-organ dysfunction that is conferred by inflammation that is coupled to an enhanced susceptibility to infectious insults. Let's construct a coherent dissection of aging-related susceptibility to lung disease. We can focus on 4 major components. First, we have altered lung mechanics compromising our functional reserve. Second, we have immunosenescence impairing the ability to respond to pathogens and vaccines. Third, we see impaired lung hygiene. Lastly, we need to consider altered tissue regeneration. With aging, possibly as a counter mechanism to malignancy, there is an exaggerated cell death and senescence with systemic infection inflammation. This reflects the loss of the supportive cell maintenance strategies, such as increased cell survival and increased cell proliferation. These 4 components translate into an organ that is vulnerable to multiple insults, but with limited capacity for protection or repair. So we get back to our patient. He clearly has mixed obstructive and restrictive lung physiology. Does this reflect actual lung disease? The lack of a smoking history or a history of significant pollution exposure, such as the use of wood-burning stoves or exposure to occupational toxins, makes COPD less likely. Small airways disease, such as bronchiolitis, is a possibility, but there is no history of organ transplant, collagen vascular disease, or exposure to popcorn flavorings, making this diagnosis not very persuasive. So aging-related obstruction is the most plausible diagnosis. What about the mild restriction? We need to obtain a chest CT to assess for early fibrosis. We should also perform studies of respiratory muscle function, such as maximal inspiratory pressure and maximal expiratory pressure. These can be done in a pulmonary function laboratory. Positive findings in either or both of these would be consistent with aging-related lung restriction. The progression in lung restriction and chest CT findings might invoke idiopathic pulmonary fibrosis. So we have no firm disease diagnosis at this point, but a provisional physiologic picture that is consistent with aging. Further, this patient should undergo exercise oximetry to see if he desaturates and possibly needs supplemental oxygen, and also should be referred for pulmonary rehabilitation. So in conclusion, we find that lung function, representing both ventilation and gas exchange, declines with aging. Aging confers increased susceptibility to lung insults. Chronic lung diseases are disproportionately represented in the aged population. And lastly, contributors to lung aging are multifactorial and can reflect immune dysfunction, impaired tissue repair, and cumulative biomechanical stressors.